immobilization. I'm guessing that's supposed to mean like not moving your arm.
Right.
I don't know what that. And if you let it continue, if continued disuse of the shoulder often leads to a vicious cycle of more stiffness with decreased range of motion, which perpetuates the problem. Typically, only one shoulder is affected, but some people eventually develop adhesive capsulitis in the other shoulder. And who is most likely to get adhesive capsulitis? Adhesive capsulitis is more likely in females between 40 to 60 years of age, and I tried to look up why it's in mostly females, and I didn't really find anything.
They may not know.
I don't know, I didn't look too hard. But other people who are more likely to get it are people with diabetes, overactive thyroid, underactive thyroid, cardiovascular disease, tuberculosis, and Parkinson's disease.
Awesome.
How you can prevent the injury. So if you have an injury and it's obviously hard to move, you can talk to your doctor about exercises you can do to maintain the range of motion in your shoulder joint to prevent from getting adhesive capsulitis. But how you can help if you already have it, how you can help with massage. If you have acute inflammation, if it's present, use MCE, which is an acronym for move, compress, and elevate. Move safely when you can. Compress soft tissues externally with bandages or cloth. Elevate when you can. And compression and elevation will help control the swelling and do not appear to interfere with the inflammation process. And once acute inflammation has subsided, you can begin massaging. Be sure to inquire about sensitivity or over-affected areas and adjust your pressure accordingly. Deep friction of the shoulder muscles reduce dysfunction and improves range of motion and decreases pain. And one way you can massage them, or not really massage, one way you can possibly traction the shoulder is to ask the client to move towards the edge of the table while lying prone and allow their arms to hang over the side of the massage table. The client's hand should not touch the floor, so you should adjust the table if you need to. Next, you can ask the client to relax and allow gravity to passively stretch and gently traction the shoulder. Get them to remain in this position for about 5 minutes. And done.
That was fantastic. That was well prepared for. And
so I'm not sharing.
Yeah, there's a way to just tell it you want to stop presenting. Cool, perfect. That was well prepared for and clear and concise. Thank you. That's exactly what we want. Yeah, adhesive capsulitis is essentially scar tissue inside your joint, inside the capsule. And that's why this is a case where cross-fiber friction is sometimes used. And I love all the suggestions. Basically what we do, if somebody, it's frozen shoulder kind of. And if somebody's got problems lifting their shoulder, we start rubbing it and we slowly lift it and we start to just work it out slowly. I love the suggestion of letting gravity do some of that for them because that way it's not overdoing it. And you just check in with the client. You just check in with the client like, is that enough? And you sit there and just work the joint. You work all the muscles that cross over the joint. You actually try to get your fingers in the joint. You can't actually really do that, but you try to get into the joint. So you would actually be working inside the joint. And you'll sit there and kind of work the area around, if it's the shoulder, all the way around the acromion process underneath it, like trying to get between the humerus and the acromion process. And you start to break up the scar tissue and you start to stretch out the shoulder. Because if they don't move it, it gets worse and worse and worse. The only thing you got to remember is don't try to fix it in one day. You do some, see how they respond. If they're fine, you keep going. That was awesome. Thank you, Ms. Young.
Thank you.
Mr. Thornton, sir, you're going to tell us about Baker cysts.
Okay, I'm ready.
Thank you, sir. Take it away.
Baker's cyst, also known as popliteal, is a fluid-based cyst behind the knee, which causes, basically, it's arthritis and a torn cartilage that causes the knee to produce too much lubricating fluid. Here's an image so far of what it looks like. it does that.
Oh, there we go. I was like, yeah.
So it's just a little ball thing right here.
Yeah.
And the damage is the symptoms that happens is basically it's a bulge and tight feeling behind the knee, stiffness, and inability to fully flex the knee.
Yeah.
So it can cause, it's basically coming off a tear in the meniscus or damage to the cartilage from conditions such as the Rheumatoid Arthritis or Osteoarthritis.
Yeah.
And it takes a while to heal. That's basically it.
Cool. Guys, so you don't really work on a Baker's cyst. The reason we have it in here, though, is because you're going to come across these a lot. And some people even have kind of leftover ones that are just there all the time that don't even bother them. But for some reason, when the knee gets injured in the backside there, it produces extra synovial fluid, and it kind of pops out as a little balloon cyst, and you'll feel like a lump. I mean, it's pretty noticeable in the back of somebody's knee, in their popliteal region, their knee pit, and you just avoid it. It doesn't really affect massage very much at all, and you can kind of do whatever they're comfortable with, but you're not trying to massage that cyst away. And some people have them almost permanently. Like sometimes they heal themselves and go away, sometimes they're just there, and most doctors are like, well, if it's not causing problems, let's not do anything with it. And so I just want to let you know, because you'll find it on the back of somebody's knee, and it's fairly common. I know friends that have this all the time. It's there. Kind of ends up becoming like a permanent little lump back there. Miss Stevens, you were going to kindly tell us about bursitis.
Yes. Can you hear me?
I can hear you perfectly.
Amazing.
Amazing.
Then I guess I will get started.
Please.
Okay, so I had bursitis, which is an inflammation or irritation of the bursa sac. We learned about these yesterday. These sacs are all over your body. They're filled with fluid to help ease the friction between tissues like around your bone. The bursa sacs are like everywhere, but they're most common around your shoulder, elbow, hip, and knee. And then bursitis is most common in anyone over 40 because as you age, the joints are like less elastic. And it's caused by repeated pressure on an area by using the joint too much, so like jumping, people that play tennis, throwing, all those things. You can also get it by sitting or standing the wrong way for too long or not stretching enough. Where am I? Oh. To fix it, you can use RICE, which was an acronym for Rest, Ice, Compression, Elevation. You can also use cold compress to reduce the inflammation and dull the pain, and then they also recommend 20 to 30 minutes of aerobic activity, like 5 times a week, nothing like too intense, obviously. And you can like massage around the area to reduce the compression and the swelling. That's all I got.
That's perfect. I just didn't want to interrupt you. That's actually all I know about bursitis, to be very honest with you. It's super common, everybody. You're going to get people all the time coming to you with bursitis. It really is those little bursi sacs that are letting like tendons run over them. It's super common, knees, shoulders, hips, like she said. If it's really swollen, don't rub it. But rubbing the area around it can really help. If you guys do ice a client or yourselves, just one thing, here's the cool thing about icing. I think every doctor out there, I'm sure there's one that doesn't, but basically every doctor out there says you can never go wrong with icing. Like you can ice the problem and it may not make it better, but you can never go wrong with icing. You can go wrong with heat. Heat actually often makes something feel better, but increases swelling. So, and people are like, oh, but it feels better when I put the heating pad on it. Yeah, but you might be making it worse. So heat is something that you want to be a little careful about. But the one thing you have to be careful about when you ice is don't ice a spot more than about 20 minutes. because you can give it frostbite. You can kill it off. Now you can take that ice off, let it warm back up, and an hour later put it on again. You can take it off and an hour later put it back on. You can do that 24 hours a day. You can ice the heck out of them, but there has to be a rest period between the icing. And I'm assuming that's what you were about to say, Miss Hendrickson. Cool. That's the only thing. But ice to your heart's content. There's a little bit of like, do we want to bring down the swelling or not? I don't know, but you're not going to make anything worse with ice. It's a great go-to, just no longer than 20 minutes. Once, actually, the real rule of thumb is once they lose all sensation in that area, you pull the ice off. When there's such a thing as ice massage, and when you're icing, which you can all do, by the way, you freeze ice in little paper cups, and it gets that nice rounded top, and you can use it to massage somebody's injury. It's actually really cool, and it goes through stages where it's cold, and then it gets burning because it's so cold, and then it goes completely numb, and at that point you're supposed to move on. Same concept. And then you can come back. Once everything kind of comes back to life, you can come back again. Very cool. Thank you, Ms. Stevens. Mr. Snell, dislocations and subluxations. Dislocations and subluxations.
Yes. Okay, so yeah, I had dislocations and subluxations. So they're both injuries, with dislocation being an injury to a joint that causes adjoining bones to no longer touch each other. And then subluxation is it's just like a minor or incomplete dislocation where the joints, they still touch, but not in a normal relationship to each other. Usually occurs like in the shoulders, kneecaps, fingers. Signs could be sudden joint pain, swelling, deformity, and limited movement around the joint. And some causes could be traumatic injuries or arthritis, things like that. And yeah, that's basically it.
Yeah, that is basically it. Thank you, sir. It's not a deep subject. Usually people use, I love you guys. Everybody's like, yeah. Usually they use dislocations to mean a major dislocation, like it's really out of joint. And subluxations mean it's slightly out of place. You'll hear chiropractors use that term a lot. They'll be like, oh, you got some subluxations. They mean your vertebrae are slightly off and they're going to pop them back. They're never far off, by the way, you'd be dead. They're just slightly off, and that's a subluxation. Well done, thank you. Mr. Singletary, you're going to tell us about fractures. Doesn't sound...
Yes, sir.
Yes, sir, please,
Sorry,
take it away.
Sorry you can't see me.
But I can hear you perfectly, which is beautiful.
Okay. Mine is about fractures. Basically, a bone can withstand pressure. However, if too much pressure is applied, the bone can start to split or break, which causes the fracture. A break in the bone is called a fracture. If the bone punches through the skin, it's called an open fracture, or in layman's terms, just a compound fracture.
Yeah.
And I didn't know this. Statistically, more than 2 million people have fractures, mostly being attributed to osteoporosis, which we know is a disease related to low bone density. There are about, what I found out is about 7 different types of fractures. One is a stress fracture. This is a type of fracture that can occur because of repetitive or prolonged pressure against the bone. Another one is a displaced fracture. This happens when the gap forms where the bone breaks. Normally, this type of fracture requires surgery to fix it. Another one is called a partial fracture. In this case, the break in the bone doesn't go all the way through the bone. Another one is called a spiral fracture. The fracture spirals just around the bone. It was interesting. I was like, wow. The oblique fracture is a break in the bone that goes across the bone.
Yeah.
Then we had a compression fracture. Here the bone gets crushed and flattened.
Those are bad.
Then another one is a transverse fracture where the bone makes a straight line across the bone. Yeah. Some of the causes that I found out that cause the fractures, it could be a fall, trauma, and I was kind of surprised that after I thought about it, I said, yeah, it's possible child abuse.
Oh, sure.
I thought, oh, yeah. I was like, oh, wow, yeah, that's right. I forgot about that part. And then, of course, repetitive pressure, such as jogging, running, playing tennis, those types of activities can cause problems in the feet, ankle, arm, tibia, and the hip. It's a lot. I'm going to skip because I'm going to be here forever. a lot to say. Okay, some of the symptoms of bone fractures can consist of swelling, intense pain, numbness and tingling to the bone, broken skin with a bone protruding, visually out of place limbs or joints, a snapping sound heard when bones break. To help spot these fractures, what many people do when they go to doctors, they have x-rays done. The x-rays provide a two-dimensional picture of the break, or they have a bone scan. This scan finds fractures that don't show up on an x-ray. They can also do a CT scan. This type of x-ray uses computers and x-rays to create a detailed image of the bone. And additionally, they could do an MRI, which I've done many times. This just shows up. It shows everything.
Sure does. Well done.
In terms of first aid, there are some steps to follow. First, yes, I found that out too. One is to check the person's airways. You want to make sure they're breathing. If you see that they had a fracture or something like that, look for other possible injuries. If the skin is broken, it says call 911 immediately.
Yes.
Do not breathe or probe the wound, because you want to try and prevent contamination. If possible, try to immobilize the broken bone with a splint or a sling if you know what to do. Once again, use an ice pack to prevent the swelling. To prevent shock, lay the person flat and cover them with a coat or a blanket. And above all, do not move the person.
Sure. Awesome.
End of story.
Thank you, sir. So as massage therapists, by the way, we are not going to see compound fractures and things like that, right? We might see it after it's been fixed in a cast, and then it's just a local contraindication. What you will have is a lot of people coming in saying they've got hairline fractures in bones. Hairline fractures, from a massage therapy point of view, hairline fractures are not something to worry about. If it doesn't hurt them in that area, you can even rub it as far as I'm concerned. If it does hurt them, don't rub it. But hairline fractures are usually like stress fractures, and they do show up in like a little MRIs and things like that that can see that kind of detail, but they're nothing to be concerned about from a massage therapy point of view. We don't usually deal with traumatic injuries, which is a compound fracture. We deal with overuse injuries, which are like the adhesive capsulitis and the person who's got stress fractures running too often, that kind of thing. Right. Yes, Miss Hendrickson, please.
I was just wondering, like, I don't know if you know, but like, if you were to overextend your elbow like this, like, or say like you land on it and it like does that, would that be a fracture or would that be like a dislocation?
Dislocation.
I was just wondering because I saw this one time. I was at the trampoline park, and my kids and this boy did something to his arm, and it was all swollen and bruised, and I like helped him ice it until like they got it out of there. But I was like, I wonder if that was a break or just like.
Don't get me wrong, it could be, but it's unlikely. It could be a couple things, but usually it's a dislocation or just simply an overstretching of the ligaments.
Oh yeah.
It's a sprain or a strain. Or there is one other possibility. It could be Miss Savarino. And that's the other possibility because she could just do that and that's fine. So they could be hypermobile. Yeah. But anyway, but usually what happens when people overdo, you could even it's not on your elbow, but in your knee, it could even get pushed backwards. And it's crazy scary. But anyway, but it doesn't break. It's just the ligaments and tendons and they push it back forward. And it just wrecks the tendons and ligaments, but doesn't even necessarily tear them sometimes. But so anyway, not a break though, not a break. It's probably not a break, yeah. Hey, that leads us to Miss Savarino. What an introduction to talk to us about sprains.
Yes. So, what is a sprain? A sprain is when a ligament, which is a fibrous connective tissue that connects bone to bone, is torn or overstretched beyond its normal capacity, and that happens when the joint is forced into an unstable position, like twisting your ankle or your knee, but you can also sprain your wrist and your elbow. I've never sprained anything, so to treat a sprain when the inflammation is present, Ms. Young kind of touched on this, the beautiful acronym MCE, which is move, compress, and elevate. The compression and elevation help control the swelling. So now that we know what the sprain is and how to treat it, you're probably wondering, can I massage a person with a sprain? Absolutely, you can. Absolutely. If you're wearing a cast, if they're wearing a cast like a split, you're not gonna want to mess with it. You know, you're not gonna want to like cut it or like, you know, you want to elevate the affected limb to prevent edema, which is a buildup in the body's tissues of fluid with like swelling and crap. So there's a bunch of studies that show transverse friction massage helps with the treatment of sprains, and obviously whenever you are working with somebody with a sprain, communication is a key factor. You know, like you're going to want to not go over their pain tolerance, you're not going to want to overstretch the area, and just tell them what you're doing and go slow and steady.
Yeah.
And that concludes my little talk about it.
That was awesome. Yeah, I couldn't really say any more about them. But by the way, sprains as opposed to strains, sprains are ligaments and joint capsules. They have to do with joints, and ligaments have to do with bone to bone, so they're joints too. Ligaments and joint capsules, and basically, if it's not swollen, you can rub it. If it is swollen, don't rub it. That's kind of a generalization. And Ms. Savarino is 100% right. It really is about the client's comfort. If they're like, oh, it's kind of uncomfortable, but it feels kind of good, it probably is good and you're fine. That's totally it. Question for you though. Would you rather have a torn tendon or a broken bone?
Are you asking me?
I'm asking anybody, actually. But I could ask you. Broken bone or a torn tendon? Mr. Thornton's raising his hand, though.
Yeah, go ahead.
Go for it, Mr. Thornton.
I would rather have a broken bone
Why is that, sir?
because the bone can heal, the tendon doesn't heal proper.
Yeah, he's absolutely right. The bone is vascular. It's actually got a darn good blood supply, and so it heals faster. Tendons and ligaments, when they're torn, they're avascular. They have very low blood supply, and they take forever. And now I'm not talking a crushed bone or some horrible thing, but yeah, very true. In general, a fully torn tendon or ligament is really, really bad, and you'd actually rather have a clean break of a bone. You'll heal quicker. Very, 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 very true. Awesome. Okay, guys, we'll take several breaks, but we just need to take a 5-minute break really quick, if that's okay. And be very honest with you, it's because I have to go tell Mr. Ibarra something. But can we take a 5-minute break and come right back? And then we'll take another one. We'll take an actual break here in a minute. So, thank you again, Ms. Savarino, for telling us about sprains that involve joints, basically, right? And Mr. Richards is going to tell us about ganglion cysts. They even sound interesting. Yes.
I am, sir, I am.
Excellent, please.
The ganglion cyst develops or grows near joints. They can be the size of a pea or grow to 1 inch in diameter. They are movable under the skin and are usually not painful unless close to a nerve. Most places of growth are the knees, ankles and fingers, but 90% of cases are at the wrist. Causes are repetitive motion injury or irritation. They are pouch-like structures filled with synovial fluid. These are more likely to develop in women, 3 times more than in men, and women between the ages of 20 and 40 years old. A theory is because of housework duties, where there is a lack of fine movements. They can decrease with rest, or sometimes they spontaneously disappear. Unfortunately, they can return. Massage will not remove the cysts, but can be beneficial in increasing blood circulation to the area. It may even cause the sac to leak, making the cyst smaller. Job done.
I thought you meant the massage job done. Job done. Yeah, no, that's perfect. By the way, I think massage this is just from personal experience, everybody. This is not some scientific thing, but I think that massage can remove a ganglion cyst completely. I've done it before. On a woman, by the way, with it on her wrist, the most typical kind of thing. And she's a dear friend of mine, and we massaged the snot out of that thing, and it went away. It went away completely and never came back. And she's like, oh my gosh, it was a miracle. And by the way, we did it with like 2 treatments, like just going to town. I've never seen anything like it before in my life. But I knew it was a ganglion cyst. I could feel the way it moved around the skin, so we were pretty sure what we were working on. And we worked on it pretty vigorously the first day. And then a couple days later, she's like, nope, it's fine. It wasn't worse or anything like that. And so then we really went to town on it, and it was gone. Like, we just went away. Miss Clayton, please.
Yeah, I want to second that. I actually, because I've been working on a computer for about 30 years, and I have a bunch of problems with my wrist and back and neck and all that, but I have like little cysts right here in both hands, and I think it's because of the mouse and the keyboard. And just since I've started this massage program, they've gotten smaller. So I do think that and that's the only thing I've done differently. Yep. So I agree with you. I think that it does help tremendously. So.
Thank you. So that's 2 people. And I massage them as though I'm milking them. So what I mean is, I know it's a fluid-filled sac, so I kind of run up to it and kind of try to push the fluid out of it, like work it out. And actually, you might want to try that actively, Ms. Clayton, now that we know. And you don't go crazy, and you do it at their pain tolerance, all that kind of stuff, but they go away. That's been my experience, yeah. Very cool. Thank you. Miss Rader, gout.
Hello.
Hi.
Okay, let me see if I can share my screen here.
Awesome.
Is it window or tab? Yeah. There we go. Okay, cool.
We got it.
Yeah. Oh. Uh-oh.
Beautiful.
Hold on a second.
All right, well, we see it good.
Give me just 1 second. I'm trying to get it to let me. Oh, it's not letting me share the whole thing. So you can see it though. That's okay.
Yes, we can. Absolutely. I know what you're talking about, but yes, we can see it quite well.
Okay. So today we're talking about gout. It is a type of inflammatory arthritis. It's a result of uric acid that crystallizes and settles into the joints. It's also sometimes called gouty arthritis or metabolic arthritis. Typically, gout develops after many years of asymptomatic hyperuricemia. I think that's how you pronounce it, yeah. Which is abnormally high levels of uric acid in the bloodstream. How does a person end up with develop gout? So uric acid is a waste product. It's normally excreted by the kidneys. Uric acid breaks down purines that are found naturally in the body. And there's also a lot of high purine foods out there that can contribute to having more uric acid in the body. Once the uric acid reaches a certain concentration, then it crystallizes. And then what happens is those crystals settle into your joints, and that's when you have a flare-up, an inflammation of gout. They've seen increased incidence of gout in men and people with high body mass index and people who consume alcohol regularly. The cause is often linked to kidney dysfunction, but in many cases the cause is not actually known. You are more likely to develop gout if you have a diet rich in red meat, shellfish, beverages that are sweetened with fruit sugars, and alcohol, especially beer. If you are overweight, your body produces more uric acid. There are certain medical conditions, high blood pressure, diabetes, things like that. Certain medications can cause it. I just put some of the ones that I thought were interesting because so many people take these things. Low-dose aspirin, medications that control hypertension, ACE inhibitors. And again, it often occurs more in men because women typically produce less uric acid, but once women reach menopause, they actually start producing more uric acid to the same levels as men. So that's when you'll find more women with developing gout after they reach menopause. And of course, if you have a family history, you're more likely to get it. And also, recent surgeries or traumas can sometimes trigger an attack. Symptoms of gout, increased joint pain, and I'm talking major pain here. It's like, I actually know people who have this, so it's like excruciating pain. It feels like you're being stabbed by a bunch of knives when you have gout pain. Usually happens in the big toe, but it can occur in any joint. The worst of the pain is usually within that first 12 hours. There could be lingering discomfort for days or even weeks after a gout attack. And also later on, after many attacks, or later on, you can end up, it can start affecting more than just the big toe. That's where it starts. Later on, you can start having it in more areas. You'll have inflammation and redness. It could cause limited range of motion. And as gout progresses, you may not be able to move your joints normally. So what we need to know about gout is that you need to postpone any massage until the client's been fever-free for 24 hours without the use of fever-reducing drugs. Afterwards, you can massage, the massage can be performed while avoiding the affected joints and nodules. You want to use a higher than normal bolster while the client is prone, in prone position to avoid the affected area touching the massage table. And then when the client is supine, you want to undrape the foot to prevent uncomfortable pressure on the affected foot. And that is all. Oh, also, there are medications that are prescribed if you have gout regularly. One of them is called Krystexxa. A lot of times they'll also prescribe like allopurinol with it. For the love of everything in the world and you and your family members, if this ever happens to you and you have to take that medication, don't stop taking it, ever. Because if you do, you'll get a massive gout attack.
Oh.
And that is all I have to say about that.
Well, that's pretty useful advice. Thank you. Really well said. I don't have anything to add except we don't really have to be afraid of, you're not going to work on this, you don't have to be afraid of even remembering all this because we should never work on anybody with a high fever. Doesn't matter why they have it. You're not really supposed to work on anybody with a fever, period. That's because that's a sign that their whole system is taxed, and we don't work on people with their whole system is taxed. And you don't have to worry about working on this joint because the client's not going to let you. It's too painful. It just won't happen. So, but thank you. Thank you for all that. That was really well laid out and everything. Thank you.
Thank you.
Really well done. Okay. Mr. Lee, you are going to tell us what kyphosis is, sir.
I'm going to try and hold 1 second, sir.
You're going to do great, sir. I'm feeling it.
Okay. Okay, hold 1 second. Let me find the big screen I can read it clear to myself.
Sure.
Oh,
take your time.
Kyphosis.
Yes.
All right, kyphosis. This condition is deformity of the spine with it. Your vertebra change from circle shape to wedge shape. Your spine may begin to curve forward. Eventually, this gives you upper back round appearance. Several different cases can result in kyphosis. It may be caused by osteoporosis.
Yeah.
This is the loss of bone density.
Density, that's good.
It makes your bone weak and brittle, it can allow your vertebra to fracture and compress. Kyphosis is also caused by degeneration of your spinal discs. It can be caused by cancer, and it can be caused by birth defects. These syndromes of the spine, if kyphosis is mild, you may not notice any symptoms. As it progresses, your spine may curve. If this, you may have an ache in your neck, and the back. Severe kyphosis may put pressure on your spinal nerves and may cause your organ to become compressed. This can cause a wide range of problems. Treatment options include medicine and experience increase your calcium intake access. Can help you strengthen your bone because taking calcium. You may benefit from the brace. People also benefit from surgery to strengthen and stabilize the spine. Your health care provider can create a care plan. I think that's it.
Mr. Lee, most sincerely, that was fantastic. I can't imagine how hard that was. You clearly covered the entire subject. I'm going to summarize some of what Mr. Lee said. I know that was hard. I'm sure it was painful, but you did great. I mean it. That's exactly what I wanted. I clearly understood what you're saying about kyphosis. So, awesome job. Thank you, sir. You guys we will all hear the word kyphosis all the time. So this is not the way we'd ever describe it to a client, but it means kind of a humped back. It is your thoracic region. Oh, your thoracic region is supposed to go out, but it really goes out. It really goes out on somebody. And it can be caused by all sorts of things. We often see it in elderly people where the bones or the discs are getting thinning, but we also see it just people that have been in poor posture for a long time, working at a desk for a long time, start to develop kyphosis. So just remember the term, and just remember it's an exaggerated curve of the thoracic region. Your thoracic region is supposed to have a curve like this. It's just a bigger curve. So it's not in the opposite direction. It's a bigger curve than should be there in the thoracic region. And sometimes just starting to work and get them to be able to lay flat on their back actually starts to help that whole thing. But some of it can't be fixed at all. When you have somebody who's 87 years old and they've got extreme kyphosis, you're not going to fix it. If it doesn't hurt them, you can still rub their back and everything. It's fine. Miss Eversole, please.
I was just gonna say too, so I have kyphosis, but it's actually in my cervical region.
Yes.
And my neck is completely curved the opposite way than it's supposed to be. And for that, it's actually not able to be corrected, because if I did get the surgery, so like I already have the metal rods in my spine, but if I got it any higher, then it would have paralyzed me from the neck down. So they said, we're just gonna keep an eye on it, and do like chiropractic work and stuff like that. But it was caused by my scoliosis.
Yeah.
So.
Thank you. And by the way, she's absolutely right. By the way, kyphosis can be any place where the curve is going out backwards behind you in exaggerated form, usually they use the term to mean the thoracic region. But she's absolutely correct. You will see it in the cervical region too. It's less common. And the reason they couldn't run the rods higher up her neck is they would have hit all those nerve plexes along the side of her neck, and you don't want to mess with people's nerves in their neck at all. Thank you for sharing, Miss Eversole. Thank you.
You're welcome.
Miss Lee. Miss Lee, you are going to tell us about lordosis. What is lordosis?
Yes, the healthy spans curve naturally from front to back. The lower back has a slight forward curve, and the upper back has a gentle backward curve. Those curves absorb shock from everyday activities like walking, jumping, or running. Lordosis is an exaggerated inward curve of the span that typically affects the lower back. A condition called lumbar lordosis less often. Children develop a pronounced inward curve of the neck, capital lordosis. Lordosis can affect people of all age. In rare cases, extreme forward curvature of the span can become painful and affect movement. Children with lordosis have a sweet back appearance. Their posture may stay exaggerated. Their buttocks may sway further out to the back than normal, and their stomach sway out in front. When children with lumbar lordosis lies on their back, it may be difficult or impossible for them to press their lower back into the floor. In rare cases, children with severe lordosis may have pain, numbness, tingling, or weakness in one or both of their legs. They may also lose control of their bladder. If your children had these symptoms, they should be seen by a span specialist as soon as possible. In many cases, doctors don't know the cause of the lordosis well. Lordosis tends to develop during adolescence. Some children are born with a higher risk of developing the condition. Lordosis is often associated with one of the following. There's 6 reasons may cause the lordosis. The one, posture. The lumbar spine relies on the muscles around the stomach and the lower back for support. Children with weak abdominal muscle tend to be more prone to lordosis. And reason 2, overweight. Extra weight in the belly button strain on the lower back and pulls it forward, increasing the risk for the lordosis. The reason 3, the trauma. Sports injuries, accident, or serious falls can cause spondylosis, type of spinal fracture. This can weaken the spine and curves the affect vertebrae to curve at a more extreme angle. The reason for surgery selected dorsal resulted minimally invasive surgery that may be used to reduce leg spasticity in some patients with cerebral and reason 5 neuromuscular conditions. Children with conditions that impair nerve and muscle function may also develop lordosis. Such conditions include muscular dystrophy. Oh yeah. Cerebral palsy and several others. And the reason 6, hip problems. Some children with developmental typically of the hip also develop lordosis. That is so. I'm finished.
That, Miss Lee, that was fantastic. That was fantastic. I'm still learning how to say neuromuscular, and you said it perfectly. I don't even know how you did that. That was great. That was great. You're done. Perfect. Really good. So everybody, lordosis, she actually said a lot of cool stuff about it that I'll summarize here in a second. But lordosis is an exaggerated curve going in. Usually they refer to the lumbar region, but it can be the neck too, right? But usually it's the lumbar region that they're talking about. It's just, that's how it's commonly used. But it means these are curves that are supposed to go in, they go in too far. So, and of course, anytime the spine's really bent up, that can cause all sorts of problems with peripheral nerves and all that kind of stuff. I want you all to think about something though, and I don't even mean answer, I just meant think about it because we're going to head to this place, because she pointed out some really interesting stuff, Miss Lee did. She commented that when people have lordosis, that their buttocks sticks out further, their gluteal region. And your spine is meant to go out at the back of my head, in at my neck, out at my thoracic region, in at my lumbar region, out at my bottom. Really is supposed to, you're supposed to look like this. These S curves all the way down, and that is a shock absorbing thing. Because if you were stacked straight up, you'd just explode your vertebrae every time you jumped. So here's the interesting thing though, and this will matter when we get to structural anatomy. Almost always, now sometimes people have surgery and stuff like that, it throws this off, but your body is always trying to get your head back over your feet. And so when one curve exaggerates, they usually all exaggerate. When one curve minimizes, they almost all minimize. So if I lose curve in my low back, I tend to lose curve in my upper back, and I tend to lose curve in my neck, and I get very military-like. If I increase curve in my lower back, my butt tends to stick out even more. My body wants to get my head back over my feet, so it's got to curve even more, and my neck has to curve even more. So I tend to either curve a lot in all my curves, or curve none in all my curves. And why this is interesting is because it's the beginning of understanding chain reactions in the body. So I might come to you and say, my neck's killing me, and you'll be like, yeah, this guy's bottom is sticking way out. That's fine, and I'm sure his neck hurts, and by the way, always rub it. Don't be like, well, it's not really your neck's not the problem. The neck's driving him nuts, but the neck really might be the symptom. In fact, it's highly likely it's the symptom. There's probably something wrong back there, and I'm down like this, and my neck's trying to get my head back over my hips. And the problem is probably in my hips or in my feet or something like that. So just kind of a neat thing to think about. Curves tend to exaggerate together or disappear together because your body's trying to get the head back over the feet. Very cool. Really well done, Miss Lee. Thank you. Yes, yay. Round of applause. Miss Pugh, you're going to tell us about scoliosis.
Yes, scoliosis is a sideways curvature of the spine and most often is diagnosed in adolescents. While scoliosis can occur in people with conditions such as cerebral palsy and muscular dystrophy, the cause of most childhood scoliosis is unknown. Most cases are mild, but some curves worsen as children grow. Severe scoliosis can be disabling, and especially severe spinal curve can reduce the amount of space within the chest, making it difficult for the lungs to function properly. There is no harm in using massage therapy to alleviate scoliosis-related pain and discomfort. Patients should be aware that the results are temporary and won't do anything to actually treat the condition. This is because scoliosis is a structural issue, not a muscular one. And that's it.
That is it. Thank you, Miss Pugh. She's right. By the way, so just really quickly so we remember the terms, right? Kyphosis was exaggerated curves going out backwards. Lordosis was exaggerated curves going in, but they're exaggerations of curves that should be there. Scoliosis is curves laterally, and there should be no curves laterally to the back. However, lots of people have scoliosis. Lots of people have mild scoliosis. And you'll know, you'll be running down their back with your hands, and all of a sudden you'll realize that you're doing a good job. You're following the bones. And all of a sudden you'll realize your hands are doing this. And you'll be like, oh, they've got a little bit of scoliosis. And some people with mild scoliosis, it doesn't bother them a bit. Other people it bothers them a lot, and I have seen scoliosis where it's like a country road. Like it really is going down there, and it shifts their whole body. And when that happens, by the way, they're usually like tight here, loose here, tight here, loose here, tight here, loose here on opposite sides because the body's trying to balance itself back out. It's got to support the fact that the ribs are all the way over here and stuff. Miss Eversole, please.
I was going to say, if you guys want to see a picture of it, I have a picture of my scoliosis. I can just share my screen.
Did you have yours corrected with surgery?
I did. I can show you both of those.
Yeah, cool.
The
Yeah,
X-rays.
please do if you got them.
Let's see. Okay, so I'm sharing my screen, I believe. It's saying 3, 2, 1.
3, 2, 1, yeah. There we go.
Okay, perfect. So, that was my back before. Can you see it?
Yes, we can.
Okay, and then that's now.
Got it.
Yeah. So,
And we still see, with all due respect, we still see the scoliosis up in your cervical region then too.
Oh yeah, definitely.
Yeah, they didn't fix that. Yeah.
Oh yeah.
So I don't know if they did this on purpose, everybody, but they actually overcorrect her a little bit because her neck goes this way, and that's smart. Because her body wants to get her neck back over her midline. Or that's her body doing that to keep it over her midline. The general rule of scoliosis is they don't like to correct it unless it's causing you lots of problems. And with Miss Eversole, I'm sure it was causing her lots of problems, so they corrected it.
Yeah, I was moving my organs.
Yeah. Yeah, and those, by the way, can also pinch all sorts of nerve. I mean, it could do lots of problems at that point. But completely safe to massage, and you will have clients, at least with mild scoliosis, all over the place. They love getting massage because it makes their aches and pains better. And it's the simplest type of massage, too. You're really rubbing them where they're tight. You're just going to notice that it switches from left to right, going down their back. You'll have one side that's really tight, and then this side's really loose. And then you go to the next place, and this will be really loose, and the next place is really tight. Okay, thank you for sharing that, Miss Eversole. Thank you for being so open, you know, with your medical situation, because it's really helpful for us to get real life experience.
Yeah, of course, I figured it would be.
Mr. Overman, you want to tell us about Lyme disease?
I do. Let me get my presentation here.
Thank you. Yeah. Oh wait, while you're doing that, hold on one second. Miss Green, Miss Green raised her hand. Yes, ma'am.
Are we going out of order? Because I'm so confused. I was supposed to go after Miss Hendrickson's. I was confused.
Maybe I skipped you. Hold on.
I think you skipped a whole like slide of people.
Oh! Let's see. I did. How did I do that?
Yeah, it was supposed to be Henderson and me, and then someone else. I was like, wow. I was like, you just I was like, did I miss it?
No, you didn't miss it, ma'am. I'm just keeping you on your toes.
Okay.
So we will get to you in about 4 more people. Mr. Overman, please take it away. Lyme's disease. You're absolutely correct, though, ma'am.
All right. Well, my notes are not popping up.
We see it.
Okay. Yeah, I have presenter notes. That's how I was going to present, but they're not popping up in this mode. So let me take it out of presentation mode.
Sure.
We'll just do it this way.
Okay, that works.
All right. So I have Lyme disease, as you know. Well, personally. So what is it? Lyme disease is a recurrent form of arthritis that affects joints, skin, heart, and the nervous system. What is the cause? Lyme disease is caused by Borrelia burgdorferi bacterium, which can be introduced into the body from a tick bite. Let's see, these ticks can be found in low brush and tall grass and wooded areas. They may be small, but they're highly mobile since deer and mice carry them. And they're most active in the summer months. So some precautions you can take are in the military. My fellow veterans in here know we always, our uniforms are always pants tucked into the boots, your undershirt tucked into your pants. So just leaving nowhere for them to get in, at least from the low brush area. They can always keep climbing, but it gives you more time to stop them. Let's see. This makes it so, I already said that. When you're done, when you're done in those kind of areas, once you get out of that environment, you should check yourself for ticks or have someone else check you for them. But make sure you and your tick checking partner do not become aroused by the full body inspection. Because it is found, Lyme disease has a 3 to 36 day incubation period. So Lyme disease, Lyme disease may be present without symptoms, and sexual activity can lead to transmission. So keep it platonic. Some symptoms are fever, headache, fatigue, and erythema migrans.
Migraines.
Is it migraine?
I actually didn't know about that symptom, so.
Okay, I assume it's not migraine and it's migraine just because it's a rash and not a headache, but I could totally be wrong there. So as you can see in the picture, it looks like a bullseye. I looked through a lot of pictures and every one I saw kind of looked like a bullseye, so that's a good indication that you probably have Lyme disease. Contraindications. So what does this mean to us as a massage therapist? Well, if the client has a fever caused by Lyme disease, it's general contraindication. So the massage must be postponed until the client's fever-free for 24 hours without using a fever-reducing medication. Once that has happened, check in with the patient before each session about symptoms, since Lyme disease can have recurrent episodes. Then, as long as everything is good, you can give the client a light to medium pressure massage while treating skin lesions and rashes as local contraindications. Be sure not to move affected joints because of the deteriorating effect that the disease has on joints. And that is all I have. This is a little OTC medication that will help with the symptoms.
That's true. Everybody knows that. Yeah.
I think this will actually help with any symptoms or anything we've talked about today.
Everything can be fought with tequila and tacos. So thank you. That was actually super helpful. Every case of Lyme disease I've ever known was associated with tick transmission. And yeah, but it can be sexually transmitted too. And yeah, I love what you said about the fact that basically you can massage them. It's just a local contraindication for the sites that they have that you would avoid anyway if you saw that kind of stuff. So perfect, good stuff. Thank you. Let's do one more and then we'll take a break. Miss Osuna, can we do osteoarthritis, Miss Osuna?
Yes.
Thank you, ma'am.
I have osteoarthritis, or in short terms, OA. So it's an inflammation of the joint capsule and progressive joint damage, which eventually leads to the loss of your articular cartilage. OA is the most common form of arthritis. OA not only affects the peripheral joints in the hands, wrists, knees, and feet, but also can affect the central joints like your hips and spine. OA can accelerate within the process of trauma, like sprains, dislocations, fractures, or maybe long-term stress. It is commonly seen within individuals with that participate in high-impact sports or who are obese, and is extremely common in elderly adults that are typically older than 75. Just because the aging process does change the articulate cartilage, and that's the main effect of OA. So with this and massage therapy, you're more welcome to continue to massage the client. You will just need to position the client for their comfort, and then before massaging that area, go over the details with them on see how much pressure you're allowed to do and how it affects them. It also has been said that the more comfort they have was when you put cold or moist heat applications in that area to help them manage it. So when massaging it, it does reduce pain and improve the functions and the joints of the arthritis.
Yeah. Beautiful. Absolutely beautiful. Yeah, we have a client that comes to our clinic here who, I mean, his hands look like this. And if he's not having a flare-up, he loves the entire session spent on his forearms and his hands. And actually wants his knuckles rubbed. He actually likes it. And it's amazing. When he comes out of the session, he looks more like this. I mean, you can still tell, but it's a dramatic change. He goes from kind of here to here. And he actually likes, you know, really rubbing over the stuff. So the kind of the rule of thumb is as long as there's not a flare-up, they're not swelling, and it feels good to them, you can absolutely rub it. Remember, this is inflammation and degeneration of the articular cartilage. This is where the two bones come together, and there's that hyaline cartilage over it that lets them slip. When that stuff starts degenerating and getting inflamed, you get some bone-on-bone situations, and it's no bueno. All right, everybody, can we take a 10-minute break, and we'll come back with Mr. Manzanares. Just to give you a heads up, we're going to come back with him. Thank you, everybody. See you in 10. Mr. Manzanares, are you there, sir?
Yeah.
Awesome. Mr. Manzanares, would you be so kind as to tell us about rheumatoid arthritis?
Yes, the rheumatoid arthritis is an autoimmune,
yes.
Yeah, it's an autoimmune and inflammation disease, which means that your immune system attacks healthy cells, causing inflammation and painful swelling. And it usually affects joints or many joints at once. Commonly affected areas are the hands, wrists, and knees. And symptoms can include pain or aching in more than one joint, stiffness and tenderness as well. Also weight loss, fever, fatigue, and tiredness. And risk factors that cause, the exact cause is unknown, but there are some risk factors that may increase a person's risk of developing RA. So the risk factors are age, genetics, smoking, obesity, especially women who have never given birth are at a higher risk. And also children whose mothers smoke can have a double risk of developing RA when they reach adulthood. And there's also a decreased factor with women who breastfeed their infants. And it's usually diagnosed with physical examination and doing x-rays and lab tests. And there are many different treatments. Rheumatoid arthritis can be treated with medication and self-management strategies. And massages can help in many different forms of arthritis. But with RA, it can improve healthy circulation throughout the joints, reducing swelling, and improve the quality of life. And like you say, avoid massaging the affected joints during a flare-up. So yeah.
That's good, sir. Well, that's really good. Thank you. Thank you, thank you. So everybody, it's arthritis that's an autoimmune disease. This is arthritis where the person's immune system is attacking itself. And they think, by the way, a little interesting side note, they think that the reason he said women who have never had children before, never given birth before, have a higher chance of getting this is when you are pregnant, your immune system actually decreases on purpose because your body doesn't want you to attack your child while they're growing inside you. And it's possible that that reduction of immunity pays off in that you don't have an extra good immune system attacking your body later because they actually find that autoimmune diseases are very prevalent in people with very good immune systems, right? But if you got a big army, you often want to go to war. And so people that don't get sick a lot have these great immune systems. Unfortunately, sometimes those immune systems go around and find other things to fight. Anyway, awesome. Don't rub it when there's a flare-up. And if it feels good to the client, it does. Done. Beautiful. Mr. Ma, we are excited to hear about osteoporosis, and I'm sure you're excited to tell us about it.
Yeah, okay, my presentation today is about osteoporosis. The word osteoporosis means porous bone. It is a disease that weakens bones, and if you have it, you are at a greater risk for sudden and unexpected bone fractures. And osteoporosis means that you have less bone mass and strength. And here's the symptoms of osteoporosis. Usually, there are no symptoms of osteoporosis. That's why it is sometimes called a silent disease. However, you should watch out for the following things. The first thing is loss of height or getting shorter by an inch or more. And the second thing is changing posture, like stooping or bending forward. And the next thing is shortness of breath. So that's because the smaller limb capacity due to compressed discs. And the next thing is bone fractures, of course. And the last one is the pain in the lower back. So the next thing is what we need to pay attention to for the prevention of osteoporosis. Like eating habits, you are more likely to develop osteoporosis if your body doesn't have enough calcium and vitamin D. Although eating disorders like bulimia or anorexia are risk factors, they can be treated. And the lifestyle, people who lead sedentary or inactive lifestyles have a higher risk of osteoporosis. And the tobacco use, smoking increases the risk of fractures, and alcohol use is the same thing. The next thing is, and it's also the last thing, is how does the massage work for the osteoporosis? second.
Take your time, sir.
So the massage helps to release tension. Oh no, sorry. So okay, massage and other holistic treatments like reflexology can be beneficial for those with osteoporosis. They will not help improve bone density or get rid of osteoporosis, but they can help alleviate associated problems. For example, massage helps to release tension, calm the nervous, and reduce stress and anxiety, increasing blood flow and lymph flow through massage can help with the healing process. In order for the bones to heal, they need a good blood supply. Increasing lymph flow not only removes waste products from the body, but also reduce inflammation, and the excess lymph is removed from the area. Massage encourages the body's natural painkillers to set in. Therefore, massage can help reduce the amount of painkillers or anti-inflammatory tablets needed. Certain aromatherapy oil can be combined with massage to aid relaxation, reduce swelling, increase blood flow, and reduce pain. Reflexology is another treatment which is a little less invasive as it focuses on the feet. It is believed that reflexology helps to rebalance the body, improve circulation, and aid with pain relief. Relief.
That's good. Yeah.
Thank you.
Hey, that was fantastic. This is why I like it when you guys do these things. I would have never thought to mention reflexology. But everybody, we will do reflexology in this class, and one of the beautiful things about it is it might be amazing and actually work. But even if you're in the camp of, oh, it's just a foot rub, it gives you an alternative for when people can't be touched in other places. Because you really don't ever want to turn away a client, right? But sometimes they come in like with a sunburn over half their body, and you can't really rub them, but they really want something done. You're like, let's do a reflexology session today. It gives you something to do, and this is a great example of that too. It gives you something to do that really might magically work, but even if it doesn't, it gives you something to do that brings a lot of relief and things like that. There's really only one, in my opinion, contraindication with osteoporosis. They're not that fragile, right? When they're getting bone fractures, it's because they've fallen down. So you can press on them. But I think you've all seen, like, the other student, Miss Sarno, when she gets up on the table, or some other student, they get up on the table and they put their knees in somebody and they're pushing down on their, I wouldn't do that type of stuff, right? They tend to lose flexibility in the rib cage too. So it doesn't spring like that, so I'm not going to do heavy compressions. But don't be afraid to touch them. They're not that fragile. But just, I would not be getting on the table and having 230 pounds of Tapscott coming down on them. Whereas I would do that to any of you without even thinking twice. And I probably will at some point. Yes. Ms. Hendrickson, please.
Is it true that doing strength training exercises can improve the density of your limbs?
Yeah, in fact, actually taking, all the studies show that taking calcium alone does nothing for you. If your body doesn't perceive it needs the calcium, you just pee it out.
Yeah.
So you need to have calcium and weight-bearing exercise. Yeah.
Yeah. Well, I read that, like, because, I mean, a lot of people say, like, drink milk because calcium. But I've actually seen studies where, like, in countries where there's almost no dairy consumption at all, they have very, very low rates of osteoporosis. But in the United States and, like, in Norway, where they eat even more dairy than us, we have, like, the highest rates of osteoporosis.
Yeah.
So it's like a very, like, clear linear progression of, like, more dairy, more osteoporosis.
osteoporosis.
Yeah, I'm actually in that school of thought, but don't. I mean, this is a very huge area of debate. But I'm on that side of that debate. But anyway, yeah. But you're right. Either way, whether you believe that drinking lots of milk is good or not, you need the weight-bearing exercise. And even just walking around is weight-bearing exercise. You know, just the stuff you guys do as massage is great. Yeah. Awesome. Thank you. Mr. Jones. Mr. Jones, will you be so kind as to tell us about patellofemoral pain syndrome? What is even the patellofemoral?
The patellofemoral is essentially, it's in the knee. But that's where the patello comes from. Yeah. And femoral is femur.
Beautiful.
It's a degeneration of the articular cartilage on the posterior of the patella. Another name is runner's knee, because it has to do with the knee, and it's typically caused by young athletes in sports, running and jumping and all kinds of stress on that sports cause. The degenerative changes and loss of cartilage can also be found on the articular surfaces of the femoral condyles. And 1 to 3% of young athletes experience knee pain, with the most common being the patellofemoral pain syndrome. And flat feet, which I didn't know, can also cause this. So I guess if you have flat feet, you're just more susceptible to the patellofemoral pain. And so, that's mostly all with young people in sports. And then if an adult has it, it's usually caused by arthritis, essentially. So you can definitely get this from not playing sports. It can happen. And so your massage approach to this would be to massage the thigh, but also to check in with your client, and obviously don't push too hard. You want to make sure that it's not causing any discomfort for them. But your goal would just be to loosen up the thigh muscles, as in the hamstrings and the quads. Also says in the book that you would offer a bolster, because basically your goal is to take stress off of, whether you're supine, it would be that would take the stress off of the quads, I believe, and if you are prone, it takes the stress off your hamstrings, so that you're able to get a better massage approach.
Well said. Beautiful. Thank you, sir.
Also, I forgot, avoid overstretching. That's important. Do not overstretch these people.
Yeah, well said. That doesn't mean be afraid to stretch them. Thank you, sir.
Yes.
That was tight. That was good. So everybody, it's your kneecap. It's inflammation and wear and tear on the inside of the kneecap, where it's going over the bone, not on the outside. So you can basically massage them all you want. And the reason that especially massaging the quads, the rectus femoris, vastus lateralis, vastus medialis, and vastus intermedius, the reason massaging all those is helpful is all 4 of those insert into your patella. The insertion of all 4 of your quads, we're going to learn this later, but the insertion of all 4 of your quads is into your kneecap, and then your kneecap inserts down into your shin. And it's designed this way for very, very good reasons, but if you want to relieve tension on the kneecap, you want to loosen up the quads. Yeah. So if you want to loosen up the whole knee, then you do the hamstrings too and all that kind of stuff. But if you want to specifically loosen up the patella so that when they're walking around normally it's not rubbing all the time, you'd hit the quads, all 4. Yeah, beautiful. Thank you, sir. Okay. Miss Hendrickson, the time has come for you. The time has come for you to tell us about spondylitis.
Let's see. You said spondylosis.
Oh, spondylosis. I did it again.
Yeah. So I actually found 2 other terms that were very similar sounding, and I put a little bit of that in there as well, just to cover all my bases.
So that I don't do this with the next class. Thank you.
Yeah. So spondylosis is osteoarthritis of the spine, which is, as we've already learned, a degenerative disorder which can cause loss of function and normal spinal structure. Primary cause is aging, but it's individual, the location and the rate of degeneration is different for each person. The spondylosis can affect the cervical, thoracic, and lumbar regions of the spine. So over time, the invertebral discs dehydrate and shrink, and the disease process may also produce bone spurs and osteophytes, which can put pressure on spinal nerves or on the spinal cord. Previous spinal injury can predispose someone to get spondylosis, and it's very common. So by age 60, 70% of women and 85% of men will have signs of cervical and lumbar spondylosis. Massage therapy can help the client manage their pain. You want to ask them about the severity of the condition and what body positions are comfortable for them. You want to ask about sensitivity over affected joints and adjust your pressure accordingly. Spinal movements should be omitted because of the deteriorating effect of the disease has on the joints. So be sure to address any coexisting conditions that can result from spondylosis, such as herniated discs in the treatment plan. And it can also result in decreased disc height and lead to herniated discs and reduced cartilage between the discs. And it's not to be confused with spondylolysis, which is a defect or stress fracture in the pars articularis of the vertebral arch, which affects 3 to 7% of Americans, and is common in teens who participate in gymnastics or football or sports like that, and which overstretching or overextending the spine but not in flexion can lead to this condition, which is small cracks in the vertebrae. And there's also another condition, so don't get confused with this one, is spondylolisthesis, which is a condition involving spine instability. And that means the vertebrae move more than they should, and a vertebrae will slip out of place onto the vertebrae below, and then that can put pressure on a nerve, which could also cause lower back pain or leg pain. And that is all of my presentation.
That was fantastic. I'm saddened to find out there is no such word as the one I try to keep making up. But thank you for trying to at least work around all that. Yeah, everybody, by the way, just the rule, again, if it feels good, you can do it. You're going to have loads of clients come in and say, I've got spondylosis. And they do say don't stretch them. What I really would say to you is, I wouldn't even be paranoid about that. But if you do something that gives them referred pain, that pain that doesn't hurt in the back, it goes to some other place, like you're stretching them and they get referred pain, then stop doing that. Because it implies you're compressing something that's hitting the nerve. And so, and don't freak out, just stop doing it. But that's all. That's all. You could probably basically, because everybody's got different levels of it, you can probably basically do anything. Just go slow with any type of movements you do that are stretching like movements and make sure you're not getting referred pain. Yeah, that was awesome. Thank you. Thank you, thank you, thank you. Miss Green, the time has come, I promise, for you to tell us about temporal mandibular disorders.
Right. So temporal mandibular disorders, also known as TMD, is a disorder of jaw muscles, temporomandibular joints, and the nerves linked to chronic facial pain. It also is a unilateral disorder. Causes of it is physical and psychosocial stress. Examples of that consist of physical stress, meaning like posture, sleeping face down with your face turned to one side or forward head, posture places, a strain on the jaw joint, and then also it said that malocclusion, or something like that, or malocclusion, or misaligned teeth and poorly fitted dentures are also a cause of that. Psychosocial stress causes behaviors such as continual teeth clenching and grinding, also known as bruxism, if I'm saying it right.
I have no idea. I've actually never heard the word before.
Yeah, it places tension on the jaw.
Yeah.
Habits like gum chewing, nail biting, or chewing hard objects, especially on like one side of your mouth, creates stress on the jaw as well. Diseases such as arthritis, cancer, and fibromyalgia contribute to TMD as well. So who it affects and how many? According to the National Institute of Dental and Craniofacial Research, it says that about 10% of the U.S. population has some form of TMD, but it's more common in women than in men. And for massage with TMD, it says that massage reduces joint clicking and jaw pain. It reduces tension in the masseter muscle, as well as increases jaw movements, including mouth opening and lateral excursion. Avoid they said to avoid prone position if because it can cause client facial pain or jaw pain. So it's always good to make sure you're asking like if they're comfortable being in prone position. Massage the muscles of the mastication, such as the masseter, temporalis, and medial and lateral. I think it's pterygoids.
It is. No, Miss Green, it is. I was waiting for you to say it. It's spelled pterygoids, but it's pronounced pterygoids. The P is silent. You're right.
Me and my mom were like all last night, like, is it a silent P or is it like, do I pronounce the P? I'm like, I'm just gonna go with it and I'm just gonna try. Like,
you said it perfectly. But I was hoping for pterygoids just so I could giggle, but you didn't do it.
Yeah, thank you. Also, it says that massage of some muscles is intraoral and requires putting on gloves.
Yeah.
Massage to the neck and shoulder muscles such as trapezius, rhomboids, levator scapulae.
Levator scapula.
Levator scapulae. Splenius muscles.
Yeah, splenius capitis, splenius cervicis, all that stuff.
We have a lot of crazy words in here, honestly.
Yeah, no, you haven't learned them yet. You're going to learn almost all those crazy words.
Yeah, and then suboccipitals may reduce uncomfortable symptoms.
Yeah.
Since TMD is associated with psychosocial stress, for some cases, massage techniques that promote relaxation is encouraged, such as effleurage. And also, it's good to encourage your clients to breathe deeply periodically to help with stress management.
Nice.
Thank you.
That was beautiful, Miss Green. Absolutely beautiful. So I want to make a couple comments about temporal mandibular joint disorder or temporal mandibular joint syndrome. They don't know what causes it. A lot of times people are just like, oh, I've got TMJ. Everybody's got TMJ. That's your jaw joint. That means temporal mandibular joint. They're forgetting to put disorder on the end of it. But they're just saying.
I saw that when I was looking it up.
Yeah, they're just saying it really quickly. But and don't correct a client when they come in and say that. Just inside you can be like, of course you have a temporal mandibular joint. Anyway, this is Tapscott's personal opinion, but I really do believe there's an emotional basis behind disease, and I think temporal mandibular joint disorder is huge evidence of that. I think when you're sending your body two different signals at once, you're going to see things show up. And this shows up in women a lot. And that is not because, women are somehow weaker. I actually think it's because they have more stress put on them, to be very honest with you. But if you are, for example, in a situation where you'd like to speak up, but you can't, you are literally saying, I want to move my jaw, but I can't move my jaw. or if you are, you know, biting down on anger, all these kind of things that we often have to do, by the way, in the real world. You know, I can't always tell my boss exactly what I'm thinking. That's not appropriate. We can't tell each other everything that comes to our head, the first thing that comes to our head. Anyway, so it does seem to be very, very stress related. And we are going to go over the exact muscles as we go through the body that affect this. But because it's stress related, you don't only work on the jaw. There's 4 main muscles in here, and one can only be reached, the medial pterygoid, by going inside the jaw, inside the mouth. But neck and shoulder tension, for some reason, seems to have a lot to do with temporal mandibular joint disorder. So you work lots of trapezius and lots of all these neck muscles that we're learning about right now. I often, with people with this disorder, work an entire hour from here up on their body kind of thing. Ms. Hendrickson, please.
Yeah, I recently had an issue with teeth grinding, which I've never done before in my life, but I thought it was a tooth problem because it was just like an area of my mouth that was like hurting, which it reminded me of when I had a root canal. It was like the same kind of pain. So I went to the dentist and thought it was that. And then they were like, well, I don't see anything wrong with your tooth at all. So I don't know what's going on. And then they sent me to a different dentist who stuck his finger in my mouth and like poked this muscle in here. And it hurt really bad. He's like, oh yeah, you're grinding your teeth. I was like, okay, thank you. So
he was poking your...
for a while, but now I don't need it anymore. Because I guess stress went down. So.
Yes, yeah, stress. That's the real key. He was poking your medial pterygoid. That's where it reaches back in there, yeah. Yeah. Very interesting. Thank you. Thank you for sharing. Yeah. Let's see. Who is... Oh! Well, let's hold on one second. Yes. Mr. Godot, you were just going to tell us the bones and joints of the shoulder girdle complex. You're just reviewing for us. Assuming that you are with us. You are. Mr. Godot? Okay, moving along. Miss Eversole, you were going to tell us the muscles that move the scapula around.
Yes, so I tried to make a presentation, but my house is just way too busy to be able to do that without any distraction.
That's completely understandable.
Muscles that move the scapula. So muscles that attach to the scapula, and correct me if I'm wrong, are the supraspinatus, teres major, teres minor, subscapularis, and infraspinatus. These attach to the scapula's surface and help in abduction and external or internal rotation of the glenohumeral joint. Then there are the triceps brachii, biceps.
So hold on one second. Ms. Eversole, you are completely right. All those muscles attach to the scapula.
Yes.
But these would be muscles that would attach the scapula to the body so they move the scapula. Those are muscles that move the humerus in relation to the scapula. Does that make sense?
Yeah, that makes sense.
Okay, so what muscles would move the scapula, like in relation to the body? What muscles tie the scapula to the body?
I have more here where it's saying the levator scapula, the trapezius, the rhomboids, and the serratus anterior.
Yes. And?
Yeah. And I have the deltoid as well.
No, not deltoid. But I'm giving you a clue right now for the last muscle.
Oh, sorry, I can't see it. Hold on. Oh, are you talking about the pectoralis major? Minor?
Minor, yeah.
Oh,
yeah.
I thought it said that, I guess not.
That's all right. That's it. Perfect. So, on the back side, there's the rhomboids major, minor, levator scapula. They tie back there. And the trapezius hooks the scapula to there. So you got kind of 4 muscles on the back side. Serratus anterior and pec minor in the front. So I think, does that give us about 6? I always miscount them. But they're attached to the body. Perfect. Perfect.
And I actually included it in like the motion for the scapula with adduction, abduction, all that, but I just forgot to write it on the top.
It's all right. Thank you. That's perfect. Thank you. Thank you. We're just reviewing. Well, we're learning so much stuff. I like to kind of go back and make sure we haven't forgotten where we've come from, so to speak.
I have like the motion and stuff, like the 6 types of motion of the scapula, if you want me to say it.
Sure, please do.
Okay, so there's adduction, abduction, elevation, depression, upward rotation, and downward rotation. And for adduction, it consists of, again, you can correct me if I'm wrong as well, but the trapezius, and specifically the middle fibers, the rhomboid major and minor, and these muscles are antagonists on abduction, obviously. And then for abduction, that consists of the serratus anterior with the origin fixed and the pectoralis minor. These muscles are obviously antagonists of adduction. For elevation, that consists of the trapezius, the upper, and the unilaterally fibers, the rhomboids major and minor, and the levator scapula. That's also unilaterally, that's a weird word to say. And these muscles are antagonists on depression. Depression consists of the trapezius lower fibers, the serratus anterior, with the origin fixed. When I say the origin fixed, meaning it does not move during contraction. And then the pectoralis minor, obviously they are antagonists on elevation. Then for upward rotation, it consists of the trapezius, which is the upper and the lower fibers, and the serratus anterior. These muscles are antagonists on downward rotation. And then for downward rotation, it consists of the rhomboid major and minor, the levator scapula, and the pectoralis minor.
Yes. Yes. Okay, that was fast, but that was correct. Thank you. Thank you, thank you, thank you. Very good. I love how you laid it all out. That was fantastic. Thank you. Really fantastic. Miss Everson, can you tell us about muscles that move the humerus? So these are muscles probably that hook the humerus to the scapula in general. I lose you too? Okay. Okay. Mr. Bose. I lost my class. Am I losing my mind? Mr. Bose, last call.
I'm here.
Oh, good. She's like, running. Run. Here, good.
Okay.
All right, Mr. Bose,
Okay.
good. I was just about to mark you absent, but you're here. We're good.
Sorry.
No,
I'm
don't be.
using my hotspot and it disconnected for 30 seconds.
It's okay. Don't be sorry. I didn't mean it like, yeah. I just, if I call on people and I can't get a hold of them, I have to. But you're here. We're good.
I have a presentation for you, but I'm just getting the app on my phone so I can share it because it's on my phone.
Okay. Do you want a minute to do that?
Yes.
Is that
please.
helpful? Okay, let's do that. Ms. Dimitrik, can you tell us about the planes, demonstrate planes of movement and stuff?
All right, I have a presentation. Let me bring it up.
Take it away. We see it. That's good sign.
Okay.
That's a good sign. We see it perfectly.
All right, planes of motion or movement. The planes of movement are transparent flat surfaces that divide the body into 3 dimensions, from front to back, right to left, and up and down. Planes are at the right angles to each other and provide references for height, depth, and width in which the body parts fall. 3 cardinal planes are the frontal, which is front to back, sagittal, did I pronounce that right?
Sagittal, I think.
Sagittal, which is right to left, and transverse, which is up and down.
Yeah. Well said.
The frontal plane, or the coronal plane, bisects the body into front and back portions. The terms anterior for the front and posterior for the back relate to the frontal plane descriptions.
Yes.
And actions of abduction, abduction, and adduction happen in this plane.
Beautiful.
The sagittal plane runs vertically whatever, from top to bottom, and divides the body into right and left sections. The mid-sagittal plane or median plane is through the midline of the body, dividing the body into equal right and left halves. The parasagittal planes are planes that do not evenly divide the body, and they run parallel to the mid-sagittal plane. Terms medial, closer to the midline, and lateral, further away from the midline, correlate to the sagittal plane. Actions of flexion, extension happen in this plane. The transverse plane, or horizontal plane, bisects the body horizontally. The body is divided into the superior top and inferior bottom sections, and actions of rotation happen in this plane. Questions, comments?
Snide remarks. No, it was perfect. It's exactly what I wanted. Thank you. You put a lot of effort into it, actually, and thank you. I just want to kind of review planes. I love that you put what motions happen in those planes. And I do not mean this as an insult to Miss Dimitrik at all, but I hope our English as a second language students see that even we struggle with how to pronounce words. Everybody in here, so we're all in this boat together.
Oh yeah.
It's not easy. It is not easy. And that's why I said, by the way, I think you pronounce it this way too, because I've pronounced stuff for 25 years because that's how my teacher did it, and then somebody comes along and goes, no, that's not how you say it. Anyway, so that was fantastic. Thank you. Mr. Bose, are we ready to rock it out now?
Yes, I am.
Awesome, thank you. Perfect.
It's gonna have me in here twice, please.
Well, you can never have too much to boast. So go for it.
Thanks. Okay. So I'm gonna exit out of this one and then join the other one.
Cool. Here we go. We see it.
I have the regions of the body. So what are the regions of the body? The body regions, they have the Latin pronunciation too. So it's regiones of corporis, maybe?
Yeah.
I don't know. It just looks cool, so I put it on there. But basically it divides the body into various anatomic districts, which can be projected by the shape of the planes onto the body's surface. So that we have the skeletal system. It's divided into two big regions, so the axial skeleton and appendicular skeletal region. There are a total of 206 bones in the whole body. Well, give or take, because sometimes people might have an extra foliage or two. These bones give your body structure, they let you move in many ways, and they protect your internal organs. So what are the two main regions? Again, they are the axial and appendicular. Am I saying that right?
Axial and appendicular, yes.
Appendicular, okay. So the axial skeleton consists of 80 of our bones. They're located along the skeletal central axis and includes the skull, the vertebral column, the sternum, and the ribs. And then the appendicular skeleton consists of the bones of the shoulders, pelvic girdles, and bones of the lower and upper extremities. There are 126 bones in that region, the appendicular region. So for the axial skeleton, again, you have the skull, ribs, sternum, vertebral column. The skull has 29 bones alone. So we have 8 cranial, we have 1 frontal, 2
parietal. I'm sorry, parietal.
Parietal? Okay. 2 parietal bones, 2 temporal, 1 occipital, 1 sphenoid, and 1 ethmoid bone. 14 facial bones, 2 maxilla bones, 2 zygomatic bones, 2 palatine bones, 1 mandible, 2 lacrimal bones, 2 nasal, 2 inferior conch, and 1 lower. And then we have 6 ear oxals. They're located in the ear, and then 1 thyroid bone. The skull also has many bones called sutural bones. And then the vertebral column, aka the spinal column, has 26 bones, 7 cervical vertebrae, 12 thoracic vertebrae, 5 lumbar vertebrae, 1 sacrum, and 1 coccyx. And then the sternum is just 1 bone within itself, and then there are 24 individual ribs, also known as 12 pairs. And then the appendicular skeleton. So the appendicular skeleton consists of the shoulder bones, pelvic girdles, and bones of the upper and lower extremities. The appendicular skeleton again has 126 bones. Shoulder girdle has 2 scapulae, 2 clavicles, and then this is also known as the pectoral girdle. Upper extremities have 60 bones in the upper extremities. There's 30 bones on each side. The 60 include 2 humerus or humeri, 2 ulni, 2 brachii, 16 carpals, 10 metacarpals, and 28 phalanges. The hands contain small sesamoid bones, which is something we discussed yesterday. If you don't remember what that is, they are the small round bones. And then pelvic girdles has 2 bones. Each bone is made up of 3 fused bones. There are 2 ilium bones, 2 ischium bones. The lower extremities, again, there's 60. There's 30 on each side. So you have 2 femurs, 2 patella, 2 tibias, 2 fibulas, 14 tarsals, 10 metatarsals, and 28 phalanges. They also contain small sesamoid bones. Those are the small round bones. And then why is it important to massage? It is important to understand the muscular and skeletal structure. The awareness of origins and insertions of the muscles to the skeleton makes it possible for us, the massage therapists, to treat our clients appropriately. Without this knowledge, it's impossible for us to be effective.
Nice. Thank you. Yeah, well laid out. I like that it had a beginning, middle, and end. I really mean that. Like here's what we're doing. And yeah, thank you. It's really good. Let's see. Missed me. Oh, Miss Deng. Miss Deng, you were gonna demonstrate actions for us.
Okay, I have to stand up and use the camera.
That's what I want you to do. Good.
Yes. This is abduction, horizontal abduction, and subduction, and opposition of the sound, and flexion, extension, rotation, medial rotation, lateral rotation, upward rotation, and downward rotation, supination, and pronation, elevation to top up, and depression, and protraction, retraction, execution. Then I need to see 1 second, take the camera down.
Oh my gosh.
This is my feet.
Oh!
And
Yay!
this is US. No, this is
Plantar.
is the elevation.
Oh, inversion. Inversion.
Inversion as elevation.
Eversion. Yeah.
Inversion and dorsiflexion. Dorsiflexion. Pantoflexion.
Yes. Yes.
Thank you.
Miss Dang, that was actually I was not even expecting all that. That was fantastic. I'm going to have you teach that to the next class. That was great. Thank you, Miss Dang. Miss Dang. Awesome, awesome, awesome. Oh my God. Oh, you showed us the feet and everything. Oh my God, I'd forgotten about some of those actions. I love that. Okay, Miss Everson, I see you. Miss Everson, can you tell us about the muscles that move the humerus?
Yeah.
So these are probably muscles that tie the humerus to the scapula. That'd be my, or to the body, but yeah.
So muscles that move the humerus, there are several muscles that attach to the humerus. I'm going to go through a couple of them and then I'm going to break some of them down because we haven't learned about all of these muscles yet. There's the supraspinatus, the infraspinatus, the teres minor, and the subscapularis, which we've learned about. Those are the rotator cuffs. Pectoralis major, tricep brachii, the brachioradialis. There's also the extensor capri radialis longus, teres major, Coraco Brachialis.
I'm sorry. And by the way, I should have told you. You didn't have to go over the ones that we haven't learned yet. But that one's called Coraco Brachialis.
Okay, Coraco Brachialis, Brachialis, the pronator teres, and the latissimus dorsi. So that was a lot. So we're going to go over the ones that we know about.
Yes, there you go.
So if you put your arm at a 90-degree angle, so you have it here, if you want to feel your greater tubercle, you're going to follow your spine of scapula to your acromion, and then there's going to be a little dip, and you'll feel your greater tubercle. And if you rotate, lateral rotation, you're going to feel an indent. That is your intertubercle groove of the humerus.
Yeah.
And then if you keep going, you're going to feel your lesser tubercle.
Yeah.
So, with that explained, there's the supraspinatus that connects to your greater tubercle bone, or section of the bone. The infraspinatus, which also goes to the greater tubercle. Then there's the teres minor, which goes to the greater tubercle and the upper lateral borders. So, subscapularis, which goes to the lesser tubercle, which is the one you can feel if you turn your arm to the side. Pectoralis major, which goes to the crest of the greater tubercle of the humerus. Then there's the teres major, and that one goes to the crest of the lesser tubercle as well, and also connects to the lateral 1/3 of the scapula. So it still is a part of moving your humerus.
Absolutely.
And the latissimus dorsi, which sits in that little space in between, which is the intertubercle groove of the humerus.
I think that, I'm not trying to cut you off, but I think that actually covers the ones. The other ones you were talking about are way down the arm, and they actually move the forearm to the humerus, and you don't need to go into those.
There's one that kind of is connected, the triceps brachii, and the only reason I say it's kind of connected is because the long head does connect to the scapula.
Yeah.
The phrygminoid tubercle of the scapula, but the other shorter head and medial head of it do not. They stay inside your humerus and do not connect to the scapula. But part of the tricep brachii does connect to the lower end of the scapula.
It does. It actually does. When we get to that, it's very interesting. Well said. I love what she did here, everybody, about coming down the spine of the scapula and being able to actually feel your greater tubercle, which 3 of your 4 rotator cuffs hook to, and then being able to feel the intertubercular groove where your latissimus dorsi comes up from underneath and hooks to, and being able to feel the lesser tubercle, which your subscapularis hooks to. It's just very helpful to actually locate those. Thank you for laying all that out. That's super duper helpful. And by the way, the one muscle you didn't mention, I think, with all due respect, was deltoid. Ha! So you did all the super difficult ones. But anyway, deltoid too. I just want to throw that out there. We're good. Thank you. That was awesome.
Your deltoid tuberosity, which is halfway down your humerus.
That is true. And there's no joke about that. Yeah.
No jokes about that.
All right. Thank you, ma'am. Good job. Before I move on, Mr. Godot, did you rejoin us? Or have we lost you for good? Okay. Oh, I thought that was Mr. Godot, but it's not. Okay. Mr. Craven, can you tell us about bone spurs in 5 minutes or less? I feel like you can.
I can probably do it in a minute.
That's what I thought. I thought Mr. Craven's like, I've got notes, we're going to go, we're gone. All right, go for it, sir,
well,
please.
You know what? I did upgrade my presentation a little bit. I got a couple pictures now. So.
Well, please, go for it.
All right, before I show you guys, just gotta let you know these are 100% real bone spurs.
Oh,
okay? Keep that in mind.
Cool. It's gonna get graphic.
Let's see. Can I do it though? That's the question.
Of course you can.
Oh, there we go.
We getting there?
I think so. This part's gonna take the whole minute, just honestly.
That's all right. We won't count that as your minute. I said 5 minutes, so you have 4 minutes to get the presentation up and 1 minute to deliver it. So.
Okay. Can you see it?
Yes. Yeah. Oh my God.
Totally real. 100% real.
Wow, I'm so glad that's not real. Oh my goodness. Wow. That's I find that disturbing for some reason. Please.
Yeah. You got another one somewhere. Here we go. 100% real. So yeah, obviously these aren't real bone spurs. Like nobody wears Crocs, so like this is come on now. But here are some actual pictures of some bone spurs, kind of where you see like the almost like a inwardly pointing actual spur. If you kind of look at this, like it's pretty similar, just like on a more realistic scale. So there's that one on the heel, and then here are some bone spurs on your spine. And they honestly they look pretty painful. They look pretty painful, and I've heard that they are. So bone spurs are also known as osteophytes. They are growths of bone that form when your body attempts to repair cartilage that has broken down. That in turn causes swelling that simulates osteoblasts to create more bone. Osteoarthritis is the most common cause, but it can also be caused by inflammation of broken down cartilage. High impact activities like running, dancing, free-form Alaskan polar bear hunting can lead to bone spur growth. They can most commonly be found in the knee, spine, hip, shoulder, fingers, and feet. And you would believe that these growths would be sharp in nature just because of the word spur, but they're actually much more like smooth. So it's hard for you to notice that you have them, so they can go undiagnosed for months, years even. According to the UPMC, taking Tylenol, losing weight, icing the area, wearing padded feet, and sleeping. And last but not least, massage therapy are great ways to treat bone spurs, of course. And then, let's see, if you find that the spur is pressing on nerves or limiting your range of motion and is not getting any better, you should probably call your nearest surgeon. Just don't wait until the spur of the moment.
Well done. Well done. Thank you. Thank you. Delivered as promised. Well done. I appreciate the humor too, actually. There really is no contraindication for bone spurs, everybody. As long as it feels okay to them, you can even directly rub a bone spur if it felt good to them. Remember that you guys kind of started out as cartilaginous little babies in life, and you were all smushy, and your body actually started to ossify, ossification, a lot of that cartilage to turn it into bone. It still has that ability to do that, and sometimes in areas of injury, it starts turning stuff into bone that it shouldn't turn into bone, and you get these bone spurs. And they can, if they press on a nerve, they cause a lot of pain. But anyway, nothing to worry about at all from a massage therapy point of view. Massage away if it feels good, it's fine. Yeah, that's really it. We will save, oh, Mr. Craven, please.
Yeah, I was just surprised I couldn't find like bone spurs or osteophytes in the book, like at all. Wasn't in the glossary, in the chapter, like, yeah.
Well, that is weird. Because I thought I got these from the book. That's why it's kind of weird. Anyway, sorry. But you did great.
You're good.
Yeah. Tomorrow we'll hear from Miss Clayton, Miss Carrillo, and Miss Avalos. I apologize we didn't hear from you today, but we had, 75 riveting presentations. So I've released homework for tonight. Just so you guys know, I actually remembered you should be able to see it. It's a lot of individual assignments. I don't necessarily think it's a lot, but it's like 5 things. There's a number 19 test on this chapter, and there's 4 videos to watch about pectoralis major, triceps brachii, biceps brachii, coraco brachialis, stuff that Miss Everson was kind enough to introduce us to today that we will be heading towards tomorrow. Ms. DeBose, please, yes. Oh, okay. Yeah, you got it. All right, everybody. Any final questions before we hit 11 o'clock? Thank you. Ms. Clayton, please.
So one thing about ice application that has always confused me. So ice is supposed to, I know it minimizes inflammation, but doesn't it contract the muscles? And if you already have a tight muscle, wouldn't that make it tighter?
Yeah, that's supposed to. In fact, if they know it's truly a muscular problem and they're not worried about other stuff, they usually recommend heat.
Okay.
Yeah, but the problem is a lot of problems aren't just muscular problems, and the heat makes more swelling. Yeah. And by the way, sometimes they alternate the two, and the reason they alternate the two is it creates a pumping action. Right, because the body tries to heat it up, cool it down, heat it up, and it causes blood to flow. And they're just trying to increase blood flow with that. But you're absolutely right. Yeah. Absolutely right about what you said. All right, everybody. I'll see you later, alligators.